Thank you so much, and thank you so much for inviting me here today. So I'm going to talk about three things. First, I'm going to kind of give a first-person perspective of why I think that supporting family caregivers is extremely urgent and important. Second, I'm going to talk a little bit about how I think palliative care can address this urgency, and I think we've seen some models already where that can be accomplished, so film spoiler. And then finally, I'm going to put on my early career researcher hat and talk a little bit about the relationship between palliative care leadership development and its importance for folks like me in order to be able to do the kind of multi-site trials that are going to be necessary to move forward the state of the science and family caregiving. So let's ask, why should we care about family caregivers? This question should probably be worded, why does Nick care about family caregivers? Because I'm going to start here in the intensive care unit. As an ICU nurse for 10 years, I called this place home. That probably sounds strange. It's very noisy. There's a lot of things going on. People are running around. Doesn't always smell great. And, we use machines and drugs to keep people from dying. But of course, we're not always successful. In fact, 1 in 5 tend to die in the ICU. What this picture is missing, though, is this person. This is that family member who, it's hard to know, like, why is she crying? Well, it could be because she just had to make decisions about life-sustaining treatments. This could be the very end of a very long caregiving road that she's just coming to the end of. It could be because, as this picture kind of symbolically shows, we have our backs turned to them, and they know that, and they kind of are anxious and upset about that sort of thing. So they make about 1.5 million end-of-life decisions per year. So nearly 3 a minute. So by the time I'm finished talking, about 30 more will have been made somewhere in the US. And it's not without consequence. About 1 in 3 of these folks are going to experience some sort of post-traumatic distress specifically related to this role for months to years afterwards. So one question, this question led to me in my PhD dissertation work doing a qualitative study of 19 of these surrogates very close to after people died. And what we found was that, unsurprisingly, surrogates are in extreme duress to actually make decisions in this role. Much of this is due to poor preparation. So the question one might ask is, can we move this upstream? Can we introduce this earlier so we're not getting people to make very high-stakes decisions under huge psychological pressure? So, and is there a way that palliative care can address this urgency? I think the answer is yes. So pictured here is Marie Bakaitis. She was my mentor for my K. And at the time when I met her in 2011, I was doing my doctoral dissertation. She was just beginning her NACNR R1-funded early palliative care trial called ENABLE for newly diagnosed advanced cancer patients and their family caregivers. So I became involved in ENABLE. I was a nurse interventionist. It's a phone-based intervention. It's led by advanced practice nurse coaches, where dyads are coached in parallel, meaning that patients have a coach, nurses have a different coach, and they have a separate curriculum. We try to engage our caregivers to think about empowering them to get their own skills in education and resources and training. And importantly, this is delivered at diagnosis, and we follow them long term. So I won't talk about what patients get, but for what caregivers get, they get 3 enabled phone sessions lasting anywhere from 30 to 60 minutes by an advanced practice nurse coach. We talk about things like how to go about solving problems, adaptive coping, partnering in symptom management and self-care, advanced care planning and decision-making. We then follow up with them each month until the end of the study or until death, and then we complete a bereavement call to make sure that they're receiving appropriate grief resources. So the findings from this study show that those who were randomized to the early group had lower depressed mood and lower stress burden, and also a trend towards increased quality of life, which is fantastic. In fact, American Society of Clinical Oncology noticed this and its sibling patient study and cited it as one of the most clinically relevant studies of the 2016 year. So we were really excited about that. So one might say, well, great, we've solved this problem, but actually we still have a really long way to go. As many thought leaders in palliative care and caregiving have expressed, both at the NACNR-sponsored caregiving event and one sponsored by NCI, there's a lot of different problems, a couple of them including we can't seem to get to underserved populations and racial minorities. And secondly, we have a really hard time scaling these into actual clinical healthcare systems. So we really need to do a better job about trying to get these into actual clinical practice. That led to sort of my future career trajectory. So I moved from Boston and Dartmouth down to Birmingham, Alabama, where I was a postdoc, now assistant professor actually at the University of Alabama, Birmingham School of Nursing. All of you should come, we have great barbecue. And so when I first got there, I started by doing this cross-sectional survey of cancer caregivers in 8 cancer centers in Alabama, Tennessee, and Florida. So I think what this confirms is what other literature has shown, is that the distress of family caregivers isn't just limited to end of life. It starts much earlier in this advanced cancer trajectory. In fact, 1 in 3 had anxiety, 2 in 5 had depression. This is consistent with other studies of these prevalences. And not only that, but these anxious and depressed caregivers were performing poorly in every area of self-care that we have a measure for, some of them listed here. So this really served as pilot data for my NACNR K99, where it was a 2-phase study. I've completed phase 1, where I've elicited feedback from family caregivers, patients with advanced cancer, and lay healthcare navigators to get a sense on what components of an early palliative care intervention would be appropriate for family caregivers. What do people want, especially in a rural setting, and especially for minorities and underserved? And then based on that outline, which looks kind of like ENABLE, but also kind of like a lot of other cancer caregiving interventions, I would do an adapted intervention and then conduct a small-scale RCT. So in K awards, clinical trials are possible. So progress to date, so far, we've conducted interviews with 26 navigators, 20 caregivers, and 20 patients. This primary paper has actually been accepted now in the Journal of Pain and Symptom Management, writing a very long protocol where we hope to begin a small-scale RCT this summer in 2018. So I was asked to kind of highlight some of the accomplishments that are in large part due to this K99 funding, and really to try and segue into some of those things, leadership opportunities that have made this sort of stuff possible for me. And so, I used to think that, being a good researcher was going to be about how smart I was. I couldn't have been any more wrong. It's also about how well they're executed, especially when it comes to clinical trials and intervention development. As many of you know, it's like running a small business. I didn't go to school to get an MBA, and so these were not skills that I naturally picked up. So it really meant developing leadership. And I just wanted to kind of highlight a few of those things that have helped me develop my leadership skills. One has been not unblind faith, but faith by our healthcare system to give me a caregiver improvement support service, where they've allowed me to try and translate some of my study into an actual clinical service. I've had a lot of support from the Palliative Care Research Cooperative Group. We know it as a clinical trials network. Another important component of it, though, is the Investigator Development Corps led by Christine Ricci. And that core serves as a huge nexus of mentoring support, as well as webinars that offer education in different research methodologies, and has been critical to my development. It also has a caregiving core chaired by Betty Farrell, which naturally fits with my interest in family caregiving. I've had a lot of thought leadership opportunities that have just been sort of given to me, which has been fantastic. This is me doing a State of the Science presentation at our annual Assembly of Hospice and Palliative Care. And then finally, I've had outstanding mentors that have modeled leadership. Several of them are sitting here, Drs. Manessis and Temmel and Miller. And folks like these have all been instrumental in being models of leaders to me and how to manage these kinds of large, complex research studies. And so it's due to a mixture of all these things that I've been able to accomplish a few things. So in conclusion, I think support for serious illness family caregivers is urgently needed. I think palliative care can meet this need. For early career neuroscientists like me to conduct these kind of complex trials that develop and disseminate these models of care, leadership skills are going to be essential. So my final concluding thought, which is more like a question, is how can the leadership development of early career researchers be promoted to advance palliative care science? Thank you.
It's really a pleasure to be here today. Thank you so much for the opportunity. I have no financial conflicts of interest to disclose. I've listed several relevant service activities. My goal today is to talk about my research on an advanced care planning tool called the PULSE. I'll talk about my experiences translating that research into practice and the translation of practice and to policy. And in fact, it's not a linear cycle, even though I just describe it as such and I will present it as such. It's very fluid and multi-directional. So the 2014 Institute of Medicine report, Dying in America, is a comprehensive review of the state of the science of palliative and end-of-life care. There is a consistent failure to elicit, document, and honor the treatment preferences of patients with serious illness. This failure is one of the largest sources of preventable medical errors in our healthcare system. Advanced directives have proven largely ineffective at addressing this shortfall. However, the Institute of Medicine did recommend that states work to adopt the PULSE, the Physician Orders for Life-Sustaining Treatment model. You may know this under another name. It's known by POST in Indiana, Physician Orders for Scope of Treatment, and other states use MOST, MOLST, or variations on these names. The centerpiece of the program is a form that's used to document patient treatment preferences as actionable medical orders that transfer with the patient throughout the healthcare system. Prior to issuing the 2014 report, I was invited to provide testimony to the IOM panel about evidence supporting PULSE, and that included my 2005 NINR-funded R01, which was designed to assess the relationship between PULSE orders and treatment outcomes. We initially piloted our approach in a multi-state phone survey of hospice staff who reported favorable views of PULSE. And then in chart reviews, we found that treatments were consistent with orders limiting interventions on PULSE in 98% of cases. The primary R01 study evaluated the use of PULSE in a random stratified sample of 90 PULSE-using and non-PULSE-using nursing homes in Oregon, Wisconsin, and West Virginia. We compared residents with and without PULSE forms. When PULSE was present, residents had significantly more orders about their treatment preferences in their medical record, and this supported our hypothesis that the use of PULSE was associated with better documentation of patient treatment preferences. Even more importantly, we found that this documentation was significantly associated with the treatments provided. Overall, residents with comfort care orders received significantly fewer potentially life-prolonging interventions, such as hospitalization, than residents with PULSE full treatment orders or residents with no PULSE at all. And these treatments that were provided were also largely consistent with the orders. I will say figuring this out proved to be a little methodologically tricky. Frankly, it's a lot more tricky than it sounds. Since the publication of this paper in 2011, care consistency with documented care preferences has been identified as a key palliative care quality indicator in the AAHPM HIPNA Measuring What Matters campaign. I co-authored a review of this metric 2 years ago, and this paper actually drew heavily from what we learned in the R01. During the multi-state R01, I also served as co-chair of the National PULSE Paradigm Task Force Research Committee. I co-led a study of state legal barriers to PULSE implementation with the American Bar Association and the National Hospice and Palliative Care Organization. Just a few months after we published our 2008 paper about state legal barriers to PULSE implementation, I found myself moving from Oregon to one of the states we had flagged as having significant legal barriers, which is Indiana. So when I joined the faculty of the IU School of Nursing, I was really unclear what my next steps were going to be in my program of research. There was no state PULSE program, and there were a lot of things going on in the environment back in 2009, 2010, as you may recall, that made it particularly unfriendly to talk about palliative and end-of-life care. However, I gave a talk about my findings in 2010 at a community presentation through the IU Health Fairbanks Center for Medical Ethics, and I was mobbed with people afterwards asking, how can we bring this to Indiana? And my immediate reaction was, well, we can't. It's pretty unlikely that's going to work. However, there was enough enthusiasm that we pulled this group together and started talking about what we actually needed to do to make it a reality. I was able to draw upon my experiences with the National PULSE Paradigm and also with the Oregon PULSE Task Force, and we ended up forming the Indiana Patient Preferences Coalition. I agreed to co-lead this grassroots organization, and we grew from our first meeting of 6 people to 74 members. We worked to put together legislation that was first introduced in 2012, and I provided testimony about the evidence supporting PULSE during the session. But the bill died in committee. Actually, everything died in committee that year. It actually ended up being a good thing. We were able to work on a few unresolved issues, and the bill was reintroduced with bipartisan sponsorship in 2013. The Indiana Post statute passed 98-0 in the House and 48-1 in the Senate with no opposing testimony, and it was signed into law by Governor Mike Pence on May 7th, 2013, took effect July 1st of that year. So, just really quickly summarize what has probably been the hardest thing I've done in my work, because it involved a lot of collaboration and cooperation with people from a range of backgrounds. When I talk about stakeholders, you should be thinking not just other healthcare professionals, but ethicists, and a large number of attorneys from all walks of life and governmental affairs folks. There was a lot I had to learn in the process to make that successful. It was a very heavy lift, and I'm very grateful to Drs. Grady and Hinshaw for inviting me to share this experience in their award-winning book, Using Nursing Research to Shape Health Policy. And if you haven't read this, I strongly encourage you to. There's lots of really exciting and interesting stories of people's journeys to translating research into policy. When the R01 outcomes were published in 2010, the PULSE model was used in a minority of states around the country, as is illustrated by this map. And for reference, the intensity of the pink on this map indicates the breadth of implementation in the state and their conformity to national standards maintained by the National PULSE paradigm. As you can see, there were just a few states that had established programs that are endorsed, many in development, and a lot of white on this map indicating there was no activity at that time. By November 2017, virtually every state in the country had a program at some stage of development. And over the years, I've had numerous state program leaders share with me that the R01 data was particularly important in generating support within their communities and support for adoption of the model within their state. PULSE is now being used to document the treatment preferences of literally tens of thousands of people throughout the United States. In Indiana, we've also worked to implement PULSE. So I told you all about the hard work in getting the law passed. It was also really hard once that passed to make sure we had the support in place around education and outreach. I worked to implement PULSE into practice, including through a program with IU Health, our academic health partner, through the IU Health Encompass program. We trained social work chaplains and nurses using the Respecting Choices PULSE facilitation model. And we also developed a video on PULSE and electronic learning modules for staff at all levels, including housekeeping and dietary and transportation. We also built PULSE into an 8-year multi-component $30 million CMS demonstration project called Optimistic. The goal of Optimistic is to reduce potentially avoidable hospitalizations for long-stay nursing home residents. In our application for that grant, our team successfully used the R01 data to argue that when you talk about avoidable hospitalizations, you need to take into account both the medical diagnosis and the resident's treatment preferences. Systematic advanced care planning is now a core component of our nursing-led clinical model. We have published on our model and our interim outcomes, and then it's also evaluated by RTI as an external evaluator for the entire initiative. The evaluation of the first 4 years of the initiative was published in Health Affairs this last year, and Optimistic was one of the top performers in the country with significant reductions in avoidable hospitalizations and all-cause hospitalizations. In qualitative interviews, the positive outcomes in Indiana were consistently attributed to advanced care planning and POST, which is a core component of our model. I am grateful to have a second R01 from NACNR to evaluate the quality of PULSE decisions in the nursing home, along with my amazing team, who's pictured here. Our first step was to conduct a phone survey of all 535 nursing homes in Indiana. Amazingly, my research assistants did not quit after that. We learned that 65% of nursing homes were using POST, with residents just 3 years after the passage of the Indiana POST Act. Our research assistants are now in the process of interviewing residents and surrogate decision makers in nursing homes to determine how well PULSE orders on file actually reflect the current values-based informed preferences of residents and surrogates. You'll also see a picture in the corner of me sharing this data from the phone survey at the Indiana General Assembly this past January during my testimony in support of a bill to add advanced practice nurses as authorized signers of POST. And this bill actually passed unanimously in both chambers with no opposition, which was frankly astonishing. This work has also been leveraged to support a new 5-year R21, R33 from NIA, on which I'm a co-PI with Kathleen Unroe, a geriatrician. We are conducting a pragmatic RCT in which we're going to develop and evaluate an advanced care planning specialist program based on our Optimistic clinical model, and we will be evaluating that in 200 nursing homes. Finally, I'm going to close with an important reminder of why this all matters. I told you lots about policy and data and practice, but I really have been grateful for the work with the optimistic nurses, several of whom are pictured here, working with residents in some of our partner facilities. And a while back, one of the nurses I trained reached out to me and shared the experiences she had facilitating an advanced care planning conversation with the seriously ill resident and her family. The resident expressed that she did not want any more interventions during this conversation, and it was documented on post. The resident died peacefully in the facility a few days later, and the nurse actually reached out to me to tell me how meaningful this part of her work was and how much she appreciated it. She also shared with me a thank you note she got from the daughter. And the daughter had written an essay, which I've never been 100% clear where that appeared. I'm guessing in a church bulletin. But she shared it and said we had permission to share it broadly. And so I'm going to read an excerpt of that essay. The daughter wrote, "What comes to mind when you think of a gift? A gift card to your favorite restaurant, a package wrapped in colorful paper topped with a ribbon or bow, a box of chocolates? Believe it or not, the best gift anyone can give their loved ones is an open and honest conversation about the scope of medical treatment they wish to receive. The post speaks for patients when they cannot speak for themselves and is a wonderful gift for family members. And we have peace of mind knowing we gave Mom a special gift by honoring her final wishes." In conclusion, NACNR's initial investment has resulted in further research as well as changes to policy and practice that impact the lives of literally tens of thousands of patients and families every single day. So thank you to NACNR for your support.
I want to particularly thank at the beginning NACNR for connecting me with a award winner and a Hall of Famer. So, because the work would not get done to understand what this population, in my case, pediatric children, infants, potentially even fetal consults, all the way up to young adults. I've been lucky to be supported by NACNR and as well as many other institutes, which I think goes to some of the sea change that we're seeing, with an ever-expanding array of people who are really thinking about how to help people with serious illness. I want to focus on three things, and I'm going to make sure that we stay as close to on time as I can. I want to talk about the capacity to do this kind of work. Children, fortunately, are usually not ill. It's fairly rare to have a childhood illness. So how do we go about studying that rare group of children? What are some of the key concepts? When we talk about gaps, the question that came from the back, one of the gaps that I see is that we have many common concepts that we talk about, like preference concordance, and Susan and I were talking before we even came in. That turns out to be a lot harder to actually measure, to understand. I'll talk about hope in that section. And lastly is what I see the sea change of rising amounts of medical complexity. We are the beneficiaries of our medical success, but we also have to deal with the consequences, an increasingly complex cohort of patients. So I'm going to pause, though, and just reflect at how it all started for me in a moment of stillness at a lake that was by a camp for kids with special health care needs, where so many of them had clearly illnesses that were not going to be survivable. But one of my mantras is dying is in fact living. Everybody who is dying is still alive. And our goal is actually to figure out how to help them live as well as possible. It turns out, over the years, I have taken a number of different ways of thinking about the needs of children who are, quote, dying. And I spent a lot of time thinking about it from large population level data, to basically be able to see the forest for the trees. Again, with an unusual, rare condition, it can be helpful to do that. In 2005, I had the extraordinary good luck, though, of meeting Joanne Wolfe, who is a pediatric oncologist and really one of the founders of pediatric palliative care. And a year later, we were talking, we said, we need to start to band together and think about how to do multi-center work. And we created what we call Peppercorn. Peppercorn has subsequently grown, and we've been able to use it as a sort of open source research collaboratory where we can partner with each other. We can potentially get to know each other well enough that we've been able to go in and write collaborative grants that have gone to a variety of institutes, as well as to do some of the work that PCRC is doing in spades so well. We were sort of developing sort of in parallel, and now we're integrating much more so. One of the first things that we did as a multi-center collaborative effort was to actually look at who is getting pediatric palliative care, or pardon me, where are these programs being developed? And one of the themes that we will see over and over again in the Q&A, and it already came out, is we are going through remarkable times. If you were in this room 10 years ago, pardon me, none of those programs existed. Okay, these are pediatric palliative care programs in pediatric hospitals. And you go from virtually none in the 2005 era and before to this explosion that occurred right before we published that paper. We can see that they are staffed, if you look all the way at the column in the middle, the range of having physicians, nurses, either in the advanced role or registered nurse, the APN nurse as a specific call out, all of these, the programs have no clear format of how they are doing their palliative care consultation. An area, an opportunity, a barrier to actually standardize what we are doing and make sure it's right-sized. We've gone on and based in part, like Susan was saying, I've been able to participate in writing 2013, the policy statement for the AAP that goes out and basically helps guide the way that we think about pediatric palliative care and hospice care for children based on the work that we have done. But what are some of the concepts that guide pediatric palliative care? Again, I can point to NACNR, and with great thanks, for basically being able to pursue a sequence of studies that have allowed me to think about hope and what is it that people, how that very, very important concept, how does it actually influence the decisions that they're making? A little bit about the duty. When we talk about making decisions for loved ones, there are two tasks that are going on, a kind of shared decision making, which you could do with me if you were helping guide me, but it becomes paired with what I am thinking about what I owe my mom or my dad. And we have not explored that as much as we should, the duty, and most recently about symptoms. So hope. I was, again, lucky. I was talking to Susan many years ago, met a gentleman via a telephone call, Rick Snyder, who was a psychologist, and helped me to start to think about the ways that people have hopeful patterns of thinking. In every study we have done, the instrument that Rick developed on hopeful patterns of thinking has outperformed virtually any other instrument we have looked at in terms of how do people handle the confrontation with adversity. Palliative care is an emotional challenge, every bit as much as a cognitive one. I would often say most of the time in the heat of the moment, it is chiefly an emotional crisis. And one of the things that we have done as we think about parents and how they cope with this situation is we need to get deeper as to how emotions are influencing preference sets and how, as emotions ramp up, they may actually change preferences, and how do we actually make sense of that both empirically and ethically. Duty. Shout out to Pam Hines, my beloved friend and colleague. Pam was working on what it meant for parents to say that they felt like they were being a good parent to their child with cancer. I started out on the other side of the country in Seattle thinking about what parents felt that they needed to do to be a loving parent. And we realized that we were circling around the same inner sense of identity of what I owe this person for whom I am obligated, I am responsible for making their decisions. So it's not just about what's in your best interest if you are my child, but what do I owe you? It's a dialogue that we really don't open up. And one of the things that we found, again, through a study that NACNR funded, was this focus on being a good parent, which we, I'm happy to report, did write up within 12 months. If you were to look at all of the ideas that people might have of what they need to do, they think they need to do to be a good parent, key point here, there's no wrong answer. Turns out most of the parents endorsed making sure my child feels loved or focusing on the child's health. This is palliative care. So immediately you start to realize they may feel that there are certain things that they have to do that the clinician, unless I ask you the question, I've talked to many parents, and I know they have an inner sense of what they need to do. What is that for you? I may not know that you're going to say advocacy, staying at my child's side, any of these things that may dominate the decisions that they make, and it has nothing except indirectly to do with what's actually best interest for the child. So lastly, I'm going to talk about the complexity of patients and their needs. Children with medical complexity is the future of pediatrics. Not to disregard essentially well child care, anticipatory guidance, all the children with lower levels of special needs. I care about all of them, but we have this new phenomenon, a product of our successful technologies and life-saving interventions that is allowing children to live in prolonged states of high degrees of medical fragility and complexity. And frankly, I don't think that we know what to do with them. We certainly are having all sorts of problems figuring out how to care for them. Our first peppercorn study, we actually noticed things like our duration in time from starting in the palliative care program, survivorship, you have most of the patients living more than a year. This is not your typical rapid decline. Here's a essentially way of thinking about all the drugs and the relationship amongst these drugs. This is actually not cancer. The question about getting beyond cancer, this is about mostly neurologic impairment. And then you can see the cardiac kids are in there with their digoxin. You can actually see it coming out of what I think of the pharmacogenomic equivalent of a network map. In our current study, where we're looking at the symptomatology, while pain is clearly a main player, the number one problem, irritability, lack of energy, drowsiness are right up there, as is shortness of breath. The child with cancer is not in any ways the best exemplar of what the typical child is experiencing. And they also have many, many symptoms. Polysymptomatology, polypharmacology is a huge issue that we need scientifically to figure out how to resolve. Lastly, to dovetail with what Nick said, if you look at their parents' distress score with the Kessler-6, 1/5, 1 out of every 5 patients, parents, is at a clinical level of distress that would warrant intervention. And they're having to take care of their very ill child. All right, so I hope to give you a taste of the need we have to continue to build capacity to really explore some of the concepts that we have a walk-around casual sense of, but they really have depth to them that I think to improve communication and decision-making, we need to push further on. And the science of dealing with the complexity are all great opportunities for us ahead. Thank you. Okay, well, we are willing to take questions, but we actually prepped a little bit in case there were none, which I'm realizing was a bad assumption that there would ever be none, where we thought about questions. What's likely to happen in the next 10 years? What are some of the trends and opportunities that we see? What are some of the scientific methodologic opportunities that we see in the field? And what are some of the implementation and translational science? So why don't you just start, Nick, with some of the things you see 10 years out?
Yeah, so in looking 10 years out, there's kind of two ways to think. It's what would you think will be the reality, and what would you like to be the reality? What will probably be the reality in some ways? Currently, the WHO estimates that about 80 million people are probably appropriate for palliative care globally. That number will probably rise, and there will not be enough specialty palliative care clinicians to touch all those folks. So in terms of looking forward, part of it will be to identify who would benefit from palliative care the most, being one focus over the next 10 years. I think over the next 10 years, we'll see an increasing integration of palliative care across different illnesses, including heart failure, COPD, other neurological diseases, Alzheimer's, and will expand. And not only will it expand into different diseases, but you'll see it move further upstream. So not just thinking of palliative care as an end-of-life care service, but you'll see it being delivered in an outpatient basis and further earlier in patients' serious illness course. I think there will be an increasing reframing of palliative care from end-of-life care to serious illness care, and that's been a real shifting of societal and cultural attitudes that the Center to Advance Palliative Care, led by Diane Myers, worked very hard to try and rebrand palliative care in a way that it's more accurate and not just end-of-life and equated with hospice care. And I think that will improve over time, over the next 10 years. From a caregiving perspective, I think that the bedside is going to extend to the home. This is going to place a lot of responsibility on family caregivers to now provide a lot of the care that a lot of us nurses would be presiding at the bedside in the hospital. We're now probably going to rely on caregivers to do just that. The length of time that people are going to live with advanced illnesses is only extending, which further places value on those tasks that caregivers are performing in the home. From an early career researcher perspective, on my Santa's wish list, I would like to see a robust cadre of sort of senior researchers out there with strong mentoring skills. I think the number of senior palliative care researchers with R01 level funding is a relatively thin lot. And so they're pretty stretched. Their mentee lists are surpassing 10, 20 folks at any one time, and that's a real pressure on them. They're trying at the same time to do their own very busy research, and so mentoring all those individuals is very taxing. And so thinking of ways to improve that situation over the next 10 years, I think would be very needed. I'll kind of stop there and let other folks comment.
We may, for the sake of time, actually move on, because I think the themes will come up in each of the questions. For you, Susan, what are some of the opportunities or promising trends you see in this upcoming period?
So I'm really excited about the focus on pragmatic trials to evaluate evidence-based strategies. I think that's really promising. I think there's some challenges associated with it, including the focus on existing data sources, which may be limited and may not necessarily be measuring the kinds of things you might want to measure. We need to be designing and testing interventions in the real world and embrace the messiness that comes with it, and at the same time, not throw away the science. So I know there's a lot of tension there that needs to be managed. Another promising trend that I see specific to the work I do is there is really an uptick in interest in palliative care. We're seeing a lot more people talking about palliative care generally, and then also advanced care planning specifically. So I've been really excited by the numerous groups. I'm part of a group in Indiana called Honoring Choices Indiana. There are about 8 different coalitions that are community-based around the state working on improving advanced care planning. Additionally, there's a lot of effort at the state level to improve policy and regulation. The American Cancer Society Cancer Action Network has actually championed the development of state councils that are focused on palliative care and quality of life. I actually chair the Indiana Council. We're seeing increased attention to what can happen at the state level in sort of a coordinated fashion to improve palliative and end-of-life care. And then another promising trend I see is focus on upstreaming palliative care, which really echoes Nick's comments, to expand people's understanding of what patients are appropriate for palliative care. And I think there's a real opportunity to upstream the research too, and broaden our focus beyond end of life and the imminently dying to the broader patients of populations with chronic illness and functional limitations. There are really huge unmet needs, and specifically, my work is focused on the nursing home. Huge unmet palliative care needs in that setting, and in the community broadly. I think there's a real opportunity there.
So maybe the next issue we'll turn to is the scientific methodologic challenges and opportunities we see ahead. I already, from my point of view, indicated some when I was speaking moments ago about the science of everything, polymorbidity, polysymptomatology, polypharmacy, in this increasingly complex mix of children, but I also look for both of my parents at the end of their lives, many, many different issues going on, and how one manages that. How does one even study it? How does one think about not just the polyness of it all, but the trajectory over time, where people are going to have anywhere from, we used to worry about just days on hospice, but if we do better, and in the pediatric realm we are, moving it upstream, people may have months or years. What do the trajectories look like in terms of, are there ways of seeing children or seeing adults who are going to have a more difficult road to travel? Is there a way of basically doing targeted interventions by being able to see that they are likely to struggle with more symptoms and caregiver burden as well? And the last point I will make is, as much as I am awestruck at how much distance we have made, serious illness, death, and dying are never going to be easy topics to talk about. They will always have a somewhat repulsive force around them. So I don't think that we can ever assume that we will win the battle. It's always going to require application to continue to be able to confront a deep human aversion to some of these issues. And at the same time, when we talk about community engagement, the conversation, though, has fundamentally changed in the healthcare arena, where people are starting to want to figure out how to use all of these interventions to help with everything from cost containment to metrics to patient satisfaction. And we're going to have to continue to think about how we place ourselves in that matrix of incentives, of potential intentionality, of what are we trying to do for patients, what are we trying to do for caregivers, in an environment that's going to bring an increasing amount of pressure as we become more visible on what palliative care can offer. What about, Nick, you for method, and then Susan? Yeah, we will, yeah, we'll end after this, so one last little round robin.
From a methodological standpoint, conducting randomized clinical trials in palliative care is very challenging. It's very hard to recruit folks who are seriously ill and their family caregivers. And this is and looking at palliative care trials, there was a recent metasynthesis, that's a real challenge. And so clinical trials are very expensive. And so I think that using the randomized clinical trial, we may also consider other types of trials, including most trials or multiple optimization strategies where we're looking at components and not just fixed packages of services. A huge question in palliative care is sort of what's in the black box of palliative care. Other trial designs would allow us to answer these questions using different kinds of trial designs.
And I'll just add, in terms of thinking about methodological challenges and opportunities, I think there's a real need for measurement development. We really lack tools to assess basic concepts. I talked about the uptick of interest in advanced care planning, which in many ways is very exciting and a great opportunity, but the science around advanced care planning is very young. And how do we assess what are important outcomes? How do we assess the experience? What does it mean to have an informed, values-based decision? These are really complicated questions that really require some focused effort. We lack that in really almost every realm related to palliative care. We just don't have great measurement.
On the All of Us initiative, and wondered if you had thought about how that might be used for future research with this focus. I had a hard time thinking of it, but it seems like that's a huge initiative, and wondered if there could be, if they were looking at some very specific populations that could.
Me personally, no, not yet. I think it will depend on how the cohorts mature. When they were doing something similar, thinking about basically a pregnancy-based cohort, I had planned to see how it went, and if it lasted long enough that we could also capture people getting ill, children getting ill, then it would allow us to really know what the premorbid states were of both not just the child, but other family members. And that would be hugely helpful for us in that we often feel that many of the families we know this, they bring to the table their past as well as their current present reality. And actually being able to start to tease that apart, it would be lovely to have longitudinal cohort data.
So I'm a symptom science person, and at NACNR we have palliative care and we have symptom science. And I view what I do as palliative care, and yet I'm not included in the palliative care community per se, because I don't wear that label.
Not yet.
And so how do we, and then the other challenge, which I'd like you to comment on, is palliative care is not the same thing necessarily as end-of-life care. Right, it includes it, but it's not the same, and I think there's some stigma then with patient population. I mean, I work with heart failure patients. Some of them aren't ready to talk about end of life, but they all have symptoms. And so also regarding your comment about needing more senior mentors, I mean, how can we bridge that? And how can we bridge the symptom science and palliative care divide if it all exists?
I mean, I think there's several opportunities for fora where we can bring together a network, both senior level investigators who are sort of from parallel disciplines, like maybe symptom science, although I don't think of them like that. But like the Palliative Care Research Cooperative every year has a biannual investigator meeting that's open really to all, as far as I understand it. And that's an opportunity for networking and building collaborations, which is what that meeting is largely for. And so I think opportunities where we can physically come together could help?
It's funny because I actually have the opposite experience where I include symptom scientists and they're like, no, I don't do palliative care. I get the opposite reaction. So
I just want to thank each of you for your wonderful presentations, very, very thought-provoking. I think the comment when Nick, you were talking about like looking to the future and the palliative care and end-of-life care, really looking at serious illness care, but that brings in again the health policy issues along with this major complexity, the the poly, multimorbidity, how do you see that? I mean, it's taking a complex issue, making it then even, because in the future, even more complex. I mean, what do you see are either some of the beginning models in terms of, I mean, you talked about design, but what are these beginning models that can look at today that can help start moving that thought in that direction?
My personal view is we need a theory of medical complexity that we don't have. People use the term casually, but underneath it, they often do not have a set of concepts that are coherently organized. So I think we need to develop the theory. Admittedly, it would be a work in progress, but we need more theoretically based approaches to thinking about medical complexity. We need a way of understanding that simplicity is what we are aiming for, but we have incentives in our current healthcare system that will keep things subspecialized and increasingly sort of separate and siloed. And that's where I think understanding preferences and goals can actually help curtail some of that. But we need a new theory and a whole new approach to thinking about how you study medical complexity and keep people as simple as possible.
I had a question for Susan. There's a bunch of research that's sort of moving discussions about end-of-life care and advanced care planning out of the clinician-patient relationship. So websites and apps and videos. And I guess I was curious of what your comfort level is with that and how much should we be moving those conversations away from doctors and nurses and social workers and patients to some of these technology-based programs?
that's a really interesting question, and it comes up frequently in the work I do, even around whether these conversations should be held between physicians and patients, or if nurses and social workers, for example, are even equipped to have conversations about goals. And I end up in that conversation quite frequently, in part because the work I do in the nursing home is an environment in which there are the physician presence is very minimal, so that focus really doesn't work. I think most of those, I'm excited about those developments, not because I think they're part of a shift in the culture, but I don't know that that's measurable, and it's certainly not a substitute for conversations with clinicians. I am of the mind that any conversation is of value, and if we have people starting to integrate that into a normal part of their lives and growing up in adulthood, and there's certainly communities in the country, across Wisconsin specifically, where they've done a beautiful job of really normalizing conversations about preferences and goals and advanced care planning. I think that's all toward the greater good. I don't think it's a substitute or a replacement for conversations with people who are knowledgeable, and specifically there are as someone becomes sicker and their disease progresses, the disease-specific context becomes increasingly important, and you're not going to get that from a website. And frankly, most of those websites aren't intended to address people at that point in their lives.
Okay, well, thank you very much. I think our time has elapsed, so thank you for listening.
Thank you so much, and thank all of you for these wonderful presentations.